Good morning. Welcome to the PGDMCH teleconference session. In our previous sessions, we had discussed about pediatrics and the gynae related case presentations. Today, we will have two family discussions related to MME 101 and MMEL 101. This will be our last teleconference for the academic year 2007. So I will request in the beginning to all the students that whatever doubt they have related to MME 101 and MMEL 101, they can ask the questions and the experts will be happy to answer them. I think all the SDC activities might have been started and some of you might have already completed. I want to point out that you have already received an information that there will be term and theory examination forms are different. So please fill up those forms. The last date has been extended to October 15th. So those who have not filled up, they can still fill up and submit to the registrar SRED. For practical forms, please fill up the form which is already there in your program guide. The old form will be applicable, but you have to submit 50 rupees per course you are planning to take the examination and submit that fee to the program in charge. For theory, the form will come to the SRE, but for practical, forms will be deposited locally to the program in charge. Today we will take up the two family presentations. One will be related to under 5 and another will be related to antenatal case. To discuss the case presentations, we have three experts here. To my right, Professor Sanjeev Gupta. He is professor at All India Institute of Medical Sciences and has been also involved in our program for the revision. To his right, Professor S.K. Pradhan. He is head of the department in community medicine at Ladihadi Medical College. He has been involved as a counselor and also program in charge of the center. To his right, Professor Jugal Kisar. He is professor at Maulana Medical College. He has been involved as a counselor, and you might have already seen many of his books. I think we will take advantage of all these experts and you can ask all your questions whatever related to community medicine component. Now I will request Professor Pradhan to moderate the discussion session, and I will also request him to tell us that why family study is so important. Dr. Pradhan, please.
Traditionally, the medical education in our country are geared for the patient. So even people perception that doctors are meant to examine only the patients when they come to the clinic or they come to the hospital, and leaving aside where he comes from, what is his problems, when he goes back, we don't know what will happen to them. So it is only the part of the illness we are treating in the hospital. So he goes back to the same environment where he has come from. So the basic objective of the clinical social case study is to study the disease process and the managing the patient in his own environment. So you will be studying the disease, the total process of the disease in his or her own environment, and we will be managing the cases accordingly, because in hospital we do not know. It will be the uniform what is given in the textbook. We apply the same management to all the patients. So it might vary with the patient to patient, background to background, other areas, his clinical socio-cultural practices. So it will vary from individual to individual and community to community. So by studying the families, the clinical social case studies, in that way, suppose we have a few students in that community they do the study. It is community-based study will be slightly different from the other study, and it is really valuable experience to have the community study. So how the community study will be, the clinical social case in the community will be different from the hospital. First, what we see in the hospital, it is the clinical spectrum of the disease. So when it is in the early or the mild case, or when it is in the other people are not symptomatic, we do not see because they do not come to the hospital. So when we examine the family, his contacts, his family members, they may be in the early phases, or some people might have recovered or recovering also. So in that case, that will give the total spectrum of the disease in his or her family or the community where she is coming from. Then we do not know, sitting in the hospital, the background, what is influencing the child care or the maternal health services, because it will be quietly different. It may not be applicable when we advise the patient in the hospital when she is discharged after antenatal care or the natal services. So we must keep in bearing whether it is only philosophical when we advise, or it is really the patient, the individual is going to practice in her own socio-cultural background. So then first objective will be, when we see the patient, her relatives, her neighbors, in that case we can find similar cases in that community. Then we know also the health seeking behavior of the people. Otherwise in the hospital we do not know what is the behavior of the people when they go for the hospital, which type of health services, whether sometimes they may not seek any health care. Sometimes we ask for any suppose allopathic system of medicine, they might go to indigenous system of medicine, alternative system of medicine. Sometimes we cannot force an individual what we feel that it is appropriate for her. Then we have to convince and motivate her accordingly. Because patient has got the option to select any type of health services that suits to her cultural practices. Then we do not know the food habits, dietary habits of the family, their purchasing capacity of the family in the hospital. So in clinical social study we know, suppose we advise something which is not culturally suitable to take the food. Some people, crude example is some people might be vegetarian, and suppose you advise a lot about non-vegetarian foods. Or there are some communities where they have got some rituals, some fast or something like that, that it cannot be uniform for every day. So when other thing is if you take the community as a whole, you find out the incidence and prevalence of the other indicators of health services. In the hospital we do not know their determinants. The denominator we don't have. We cannot monitor whether the community is progressing or not progressing in other health indicators with time, with our intervention, with our input in our healthcare delivery system. Then sometimes any communicable disease we manage the case, but the patient there will be the main source might be reservoir or infection will be elsewhere. So unless we tackle the community as a whole, then there will not be any management of the removal of the cases and the reservoir from the community, and it will be potential source either intermittently or continuously to the neighbors or the community. In this current age where the travel is so fast, so you cannot locally geographically say that this is from this community, this area, because there will be a potential threat to rest of the state or the district, because if the patient in the incubation period or other carrier state travels to other part, then it might be a source of threat, health hazards to the other part of the country, and people will be at risk. So in that case, when you are finding the other thing, we combining the cases in the community by community study, we can make a community diagnosis, which is quite relevant and important to have a community diagnosis, because what the community feels may not, their need may not be what we feel our need. The health need of the community will be different for the health need what is the provider or the government or any other agencies or doctor thinks that is the need. It completely might be different. So their need can be only studied by studying their cases in their own environment. Then the dynamics of the disease process cannot be understood clearly in the hospital setting. So the dynamics of disease process, transmission, control measures, community participation, motivation of the people, these are the things which can be only taken to the community. Because you cannot advise individual at the hospital, and these are the issue, because unless the community participates or they are motivated, it may not be a long-lasting remedy for any health issues in our community or in the country. So just the clinical social case study is very important one in that way, because you are studying the individual, taking the socio-cultural and the environmental factors in background where he or she is coming from, and we are managing the case in or her environment.
Thank you, Dr. Pradhan, for nicely summarizing the importance of doing clinico-social study. Indeed, unless you go to the family, unless you go to the community, the whole spectrum of the disease is very difficult to perceive. Now I will request the student who is representing all of you, Dr. Chetan Grover, to make the case presentation, and I will request the experts to moderate the presentation. Dr. Chetan Grover.
Good morning to today's panel of experts and dear colleagues. Today I am presenting the case of Krishna, who is a 3-year-old male child. He is the elder of the 2 children of a nuclear family, migrated from Gorakhpur, UP, and they are now staying in the area of Pilanji in New Delhi. The chief complaints of the child, as per the mother, decreased appetite for the last 15 days and pain abdomen off and on for the last 10 days. The mother of the child says that the child's appetite has decreased slowly over the last 15 days. He is also complaining of pain in the umbilical part of the abdomen, off and on. Pain is colicky. It usually starts after eating a meal and accompanied by passage of loose stools. There is no history of radiation of the pain to any other part of the abdomen. There is history of passage of worms in the stool. There is no history of vomiting. There is no history of any micturition problem. There is no history of any ear discharge. There is no history of convulsions or rash. There is no history of pica. There is history of eating from the vendor standing outside the school. In the past history, the child gives the history of a similar illness in the past 6 months back, for which he was given treatment for 5 days and he was cured of his problem. There is no other history of any prolonged medication or hospitalization in the past, and there is no history of a similar illness in the family. In the immunization history, the child is fully immunized as per his age. In the personal history, the child is going to a play school in the mornings. He brushes his teeth every day, takes a bath daily. He wears chappals and shoes while he is outside and inside the house. He washes hands with soap after defecation. In the dietary history, the child is taking an intake of 1200 kilocalories per day as against the requirement of 1500 kilocalories per day. He is taking a protein intake of 10 grams per day as against his requirement of 15 grams per day. In the general physical examination, the child is conscious, cooperative, well oriented in time, space and person. He is showing some pallor. There is no jaundice, no cyanosis, no edema. Fontanelle are closed. There is no frontal bossing. Hair are black and shiny. Skin texture is good. Conjunctiva, tongue and nails show pallor. The child has 24 teeth. 2 teeth are showing cavities. There is no conjunctival xerosis or bitoid spot seen. There is chelosis at the angles of the mouth. Cervical, axillary and inguinal lymph nodes are not palpable. There is a BCG scar on the left arm. There are no knock knees or flat feet. In the vitals, his pulse rate is 80 per minute. Respiratory rate is 16 per minute. Regular good volume. Temperature is 36.5 degrees centigrade. In the anthropometric measurements, the child weighs 13.5 kgs as against the expected of 15 kg. His height is 94 centimeters. Head circumference is 50 centimeters. Chest circumference is 52 centimeters, which is as expected for his age. Mid-arm circumference is 12.5 centimeter. His immunization is complete for his age and milestones are normal as per his age. In the systemic examination, in the respiratory system, the air entry is bilaterally equal on both sides. No adventitious sounds are heard. In the cardiovascular system, S1, S2 heard normally in all the 4 areas of the heart. There are no murmurs or added sounds. In the central nervous system, higher functions are normal. Cranial nerve examination is normal. Power and tone normal in both the limbs. In the abdominal examination, abdomen is slightly protuberant. There is tenderness on deep palpation in the umbilical and iliac areas. Liver, spleen not palpable, and no other masses are palpable. As per the family history, it is a nuclear Hindu family with 4 members. The head of the family is the father of the child, who is Mr. Sugriv. He is a 26-year-old male, educated up to 12th standard and working as a guard in a private bank. He is earning rupees 4,000 per month. He is not addicted to tobacco, alcohol, bidi, cigarette, and his present health status is good. He does not give any history of prolonged medication, illness or hospitalization. The next member of the family is Mrs. Vinita, who is the mother of the child. She is a 24-year-old housewife and educated up to 5th standard. Besides looking after the family, she is doing some home-based work and earning about rupees 300 per month. She is having a goiter, for which she was advised surgery. There is no history of any other illness in the past. The third member is the index child Krishna, who is the 3-year-old school-going child. The fourth member of the family is a 9-month-old breastfed infant named Piyush. His anthropometric measurements are: he is weighing 8.5 kgs, length 72 centimeters, mid-arm circumference is 13 centimeters, head circumference is 44 centimeters, and chest circumference 43 centimeters, which are all normal as per expected for his age. Immunization is complete and health status is good. As per the housing, the family is living in a crowded and unclean locality. They reside in a single room accommodation on the 2nd floor of the building. The room is about 11 by 11 feet in size with 1 door and 1 window. There is a desert cooler which is fitted on the window, and the kitchen is inside the room. The lighting and ventilation are inadequate. The toilet and bathroom are common between 7 other families who are residing on the same floor, and there is a separate area for washing utensils and washing the clothes. The family is not changing the water of the desert cooler regularly. In the water supply, there is a tap water supply in the toilets, washing area, bathing area. Water is drawn up by an electricity motor and available for 24 hours a day. The drinking water is collected from a Delhi Jal Board tap from a distance of 250 meters every day in a container, and the same water is also used for cooking purposes. The refuse disposal is done in an MCD garbage dump near the house after being tied up in a plastic bag. For the excreta disposal, the toilet is connected to a sewer line. The health-seeking behavior of the family: for minor problems, they go to the Urban Health Center, Pilanji, which is next door to the house, or they also go to a private practitioner in Lajpat Nagar. For antenatal checkups, deliveries, vaccination, they go to Maternity Hospital, Lodi Road, and Safdarjung Hospital. As per the customs and the child rearing practices of the family, breastfeeding is done up to 2 years of age, weaning at 7 to 8 months, colostrum is not discarded, no prelactal feeds are given, and the couple is using barrier method of contraception. They are not planning to have any more children. The family is mostly following the advice of doctors during pregnancy, child rearing, since they are away from their native village and away from the relatives. The provisional diagnosis of this case, it is a case of the child Krishna, is a case of colitis with worm infestation, with anemia, with protein energy malnutrition grade 1, with immunization complete for age, with normal growth and development. Summarizing this case, Krishna is a 3-year-old male child with chief complaints of decreased appetite and pain abdomen for the last 15 days. He is having pallor, tenderness in the abdomen and angulokylosis. He belongs to a low socio-economic status family living in an unclean and crowded locality. His provisional diagnosis is colitis with anemia with worm infestation and grade 1 protein energy malnutrition. In the management of this case, the investigations that can be done are routine hemogram and stool examination. Treatment that we will prescribe to the child is deworming, course of anti-amoebic drugs, antispasmodics and hematinics, and follow-up after 1 week. The preventive measures we can take up in case of the patient are by giving a diet rich in green leafy vegetables, increase in protein intake, periodic deworming, prophylactic iron folic acid, intake of hygienic food materials, and supervision by the mother for hand washing before eating and after defecation. At the level of the family, the preventive measures that can be taken up are intake of clean and hygienic food, proper washing of the fruits and vegetables, keeping the surroundings of the house clean. At the level of the community, maintenance of cleanliness on the roads by the civic agencies, enrollment of the child in the Anganwadi, daily pickup of garbage from the garbage dump by the civic authorities, and tying up of stray animals. Thank you.
Doctor, could you explain to us, when you say adequate vaccination for age, adequate immunization for age, what exactly is meant by that?
The child was born in Safdarjung Hospital, so at birth he received his the 0 dose of oral polio vaccine, hepatitis B vaccine and BCG vaccination. Then at the age of 6 weeks, he got his first dose of oral polio vaccine, DPT vaccination, and second dose of hepatitis B vaccination. Then after 1 month, second dose of DPT along with hepatitis B, and after 1 month along with oral polio, and then again the 4th dose of oral polio and DPT, and at measles at 9 months of age along with vitamin A syrup, and also got an MMR vaccination at 14 months of age, boosters of DPT and oral polio at 1.5 years of age.
Any subsequent vitamin A doses?
Yes, along with the boosters of DPT and oral polio, he also got another dose of vitamin A.
You made the diagnosis of the child as the colitis, worm infestation, grade 1 malnutrition and anemia. So in this case, can there be any common problem which leads to all these clinical entities like borderline malnutrition, anemia, worm infestation? Can it be multiple causes, or it can be one spectrum, spectrum of the same problem, multiple spectrum of the same conditions?
All these problems may be related to intake of unhygienic and unclean food, not cutting the nails properly, not washing hands properly after defecation, and plus this can give rise to these problems, all of them together.
So when the child is coming from one of the colonies like Pilanji, you told, what should be the services available for a 3-year-old child? Actually, 3-year-old child, what are the services should be available for this type of illnesses which could have been prevented?
Child should have been preferably been enrolled in an Anganwadi, and their supplementary nutrition could have been given, and proper health education and advice to the child and to the mother could have been given, and this at the level of the community this could have been done, along with of course maintaining the cleanliness of the surroundings of the locality. So there is a lot of dirt and garbage littered on the roads there, on the streets.
So, what specific you have told about the deworming, periodic deworming you have recommended for this type of children, 3-year-old child in this community, and what specific diet you recommend for a 3-year-old child? Specific dietary intake for a 3-year-old child in this type of family.
The child should be given a diet rich in proteins and calories. His protein requirement is 1 gram per kg per day, and as per his expected weight of 15 kgs, he should be taking an intake of at least 15 grams of protein per day. And he should be given all the foods that are cooked in the family as the elders are eating. He should be taking vegetables, dal, egg, and if the family is also taking non-vegetarian food, in this case they can take meat or chicken once in a while. And of course he should be taking milk, and at least a diet of about 1500 calories per day.
So what specific advice you will give to the mother to give as food to the child, so that the child will get 1500 calories or that amount of protein you have recommended? What the child should consume, in what form? Because mother may not understand 1500 calories or 20 grams or 40 grams of protein. So what specifically you will tell the mother that what her child should take, so that in that process the body will get that much calories or protein?
We will ask the mother to give at least 3 major meals and 2 snacks, nutritious snacks in between. Since they are mostly not able to afford non-vegetarian food every day, so at least the child should be taking 1 katori of dal 3 times a day, along with some green leafy vegetables, and at least 1 egg per day, and milk 2 times a day, and at least should be taking 2 chapatis or 1 bowl of rice, and also can add some oil and fat to the child's food. Make it a little.
Just another thing I wanted to do, they have got 2 children. So they feel that they have limited their family size. They don't want any more children. Then why they are not opting for permanent method of contraception, then they are opting for barrier methods?
Because the younger child is only 9 months old, and I think as per the advice of the doctors also, and they are also little insecure until the children grow up. They do not want to go in for a permanent method of contraception, so that they might need to have another child in the future if one of them is not, any problem takes place with the children or something.
Okay, I want to say, as far as the diagnosis is concerned, it's my suggestion that if we add that you have taken the history of environment, also the family history and everything you have taken, but in the diagnosis they should reflect. You should say that the overcrowding is present. Some social problem, if it is there, it should be highlighted in that diagnosis. Also, I think in social problem, like you have said, they belong to lower class. But is there any smoking history? You have said yes.
No.
No.
The father is not smoking.
Or alcoholic.
No.
Or any interpersonal relationship which is disturbing in the family. If you highlight those things, I think that make sense. While you're managing, you can handle those issues also side by side. You have taken the history of water supply, but in water supply, the water storage, you have not focused on how they are storing the water, how they are using it. That could be a very important aspect.
Yes, sir. They are not boiling the water, they are not adding any chlorine tablets, they are just collecting it from the Delhi Jal Board tap and using it in a, keeping it in a plastic container.
Plastic container. And that container has to be washed. So are they washing it or not?
It has a narrow neck actually,
so
they are not washing it.
That is very dangerous. You know, when it is narrow, how you can clean it? So that is might be the source of infection. And I think in diagnosis, if you include all the components of environment, social and occupational and also the clinical, that could be useful for your management.
Yes.
Thank you. In the elder child, Krishna, she breastfed the child till about 2 years of age, and then they started supplementary feeding.
No, they started supplementary feeding at about 7 months of age, along with breastfeeding,
okay,
up to 2 years.
Because in this particular family, we got an excellent example of a second child who's right now in that particular stage. Where in case they have committed any errors in feeding the elder child, they can be rectified in this particular child. So in this child, so maybe they advise the lesson from the elder child can be applied to the younger one also in this particular case.
Another thing you told that which you have missed, I think, or you didn't include in your diagnosis, the child has some cavities in the tooth.
Yes, sir.
So suppose this is a child, 3-year-old child. So what I make out, it can be dental caries.
Yes, sir.
So how you will recommend so that the other teeth do not suffer from them and the younger child do not get caries when she grows up?
So the child is only brushing teeth once in the morning, so we will advise him to brush his teeth every night also, and plus brush his teeth after, in fact, every meal if possible, but at least before going to bed he definitely must brush his teeth. That can be the cause of caries.
And you know, the way the brushing is done should be told to the
proper method of brushing can be told to
and
the
also
mother.
After brushing, the child should not drink milk or eat afterward. After in the night, if brushing is done, then the child should not eat after that.
In the management, if you just repeat the measures that you said for the management of this family.
The preventive measures?
No, the previous, the immediate management.
So we can get investigations like hemogram done to check for the amount or the level of hemoglobin and how much hematinics we need to give and for how long. We will get an idea from there.
Okay.
And in the stool examination we can look for to confirm our diagnosis, look for cysts or ova. And also if there's any bacterial infection, we'll also get an idea from the hemogram if the total leukocyte counts or neutrophils are raised, any kind of bacterial infections.
And the preventive measures, there will be essentially nutrition and iron folifer.
Yes, and more stress on hygienic food materials, like because the child is eating from the vendor standing outside the school.
Okay. I think what we need to add in this is probably, it may be implicit, is growth monitoring of the child. So whenever we have a child who has got any grade of malnutrition, or for that matter any under 5 child, it has to be growth monitoring, nutrition, vaccination, vitamin A prophylaxis. That's the way it has to sort of proceed. So very often we tend to advise the mother for nutrition and for the other preventive measures. It has to be emphasized the child has to go periodically for weight assessments. And though this community may not have too much of vitamin A deficiency, that should carry on till the age of 5 to 6 years preferably.
And in the diet also, if you are advising, you should assess that what the child is already taking, and you have to improve on that diet rather than totally shifting and changing to a new diet. Or if it's the case of grade 3 or grade 4 malnutrition, so that increase should also be slowly, and maybe we can whatever extra require the first week or 15 days we should give half of the extra requirement, and then add subsequently.
In the family, there are some other members also you have examined, and you have told that the mother has got a goiter and lost thyroid. Do you think the mother has been investigated for that, or advised some management for the goiter, and will that enlarged goiter will have some bearing in the health of the children in the family?
Yes, so the mother was investigated in the hospital and she was advised surgery, and there can be a possibility of hypothyroidism in the children also, because if there is a decreased iodine intake generally in the family taking place, so we can also look for signs of hypothyroidism in the child and take measures to prevent it.
What is the recommended iodine intake at the family level per capita?
Not too sure.
From the salt, orally how much they should consume?
Normally if the iodized salt is consumed by the family, that will take care of the daily requirements.
Okay. Then in the specifically, have you asked for the what are the things to look for the personal hygiene of a child? Personal hygiene for a 3-year-old child, and how the mother should look after them, and specifically which of the components of personal hygiene in a 3-year-old child should be looked after by the mother?
We should ask the mother to make sure that the child is washing his hands properly with soap before eating his meals. His nails should be clipped every week, and he should be given a daily bath, and his ears should be cleaned to prevent ear infections, and of course ensure that the child doesn't walk bare feet when he goes, especially out of the house, also preferably inside the house also should be wearing shoes or chappals.
What are the wrong foods children are susceptible at this age when they are away from the families, going for play school or anywhere, and when they have some amount of pocket money?
Normally they take sugary food stuff like sweets, toffees, and sometimes things which are sold on open by the vendors on the open carts, like cut fruits or some salty snacks, which are just lying open in the open. So, and plus some ice creams also, they can also be a source of infection, cheap quality ice creams. And sometimes like sugarcane juice, which is being sold on the roadside, this is also a big source of infection.
Then coming back to the water supply, they have only access to the public water supplies?
No, they have an electricity motor, and the water is pulled up by that electricity motor and stored in the tank, from where they get the water supply of the toilet, bathroom and washing utensils. For the drinking water, they are going to outside to collect the water, but they are not boiling the water, filtering the water or adding any chlorine tablets.
Suppose you feel that the water supplied by the municipality is safe. So what precautions she should take so that it doesn't become unsafe in her house?
She should preferably wash the container which stores the water every day before storing, and preferably she can keep 2 containers of water. One can be used to collect the water, the other can be cleaned up the same day, and it should have a wide neck so that the hand can properly go inside and clean the container properly from inside. And the container should also be kept covered so that nothing falls into it once it is kept in the kitchen.
Can there be any alternatives? He can take water without putting something into the bucket?
Yeah, and they can also install a tap at the bottom of the container so that they don't have to, or the children may also put the hand inside to take out the water for drinking, or even the lady herself may put an unclean container or a glass or a cup to take out the water, so they can have a tap at the bottom of the container. That will prevent infection.
Okay, you told, I think, about the cooler and the taking out the water, that they are not changing the water.
They are not changing the water, yes.
So what do you anticipate?
So there may be breeding of mosquitoes is likely to take place in a stagnant water, and then of course problems related to mosquito breeding like malaria, dengue, they may start coming up. And since it's a very crowded and dark, poorly lit area, the house and the whole floor, so there may be breeding of mosquitoes and further problems.
So in the provisional diagnosis, when you are putting the family diagnosis and the problems you are identifying, you have to identify all the problems where you have to intervene. Just like Dr. Jugal identified that okay, you have to tell the other areas. So wherever it may be social problem, it may be clinical problems, it may be all the problems have to be identified. When you are summarizing the case, at least you can do all those things. One more thing I want to ask regarding the growth monitoring. How will you ensure that the child having this child, 3-year child, the growth monitoring can be done in the community itself? Who will do that?
The Anganwadi worker should do that. The child could be enrolled in the Anganwadi, or even if the child is going to a private play school, the Anganwadi worker should visit the house regularly and take the weight of the child and plot it on a growth monitoring curve, so that she can advise measures before it gets more severe or the malnutrition progresses further. She can give an early warning to the family.
Okay, regarding this child, it is a fine. You have taken the case in the Safdarjung hospital.
In this neighborhood of Pilanji, which falls under the
Pilanji. So how will you ensure that this child will be followed up? If you are a medical officer, for example, in that area, how will you ensure that the follow-up of the child takes place? How will you follow up the child?
We can, since the urban health center is very close by to the house, we can keep a record of all these children who are showing early signs of malnutrition, and make sure that we follow them up by going house to house, or we can motivate the family to come back every 15 days or every month to get the child checkup, since it is very close to their house. So we can motivate, and otherwise we can visit personally, we can send the health worker.
Yeah. So I think we have already listened to the case presentation as made by Dr. Chetna Grover. So what I will request the students, whatever family you have worked up during your spell training, you may even practice that before your term and practical examination, because the whole idea of this exercise is to prepare you for term and practical examination. So whenever you are making a family study, you can make it, the approach could be as an index case. You take up the index case, then enter the family, take the details of the family. Or you can go to any family, you do not know what is happening in the family. You can study the family and you can pick up the index case, or you can pick up any morbidity in the family. So that you complete the exercise, and after you identify the problems, you have to not only manage clinically, you have to also see that how these problems can be prevented, and also you have to ensure that the services that the family is taking, what are the health facilities available all around, and how these this family or the problems in the family can be followed up. So all these you have to take care, you have to advise the family accordingly. If required, you have to do the counseling, as you have learnt already in IMCI, or maybe there is some adolescent problems. So you have already learnt that there are few units in your PGDMCH modules regarding the adolescent health. So whatever problem you identify, be it adolescent, be it under 5, be it pregnancy or antenatally related, or be even the social problems, maybe drug addiction, maybe alcoholic, smoking. So all these areas you have to identify, and you have to give suitable advice, whatever is feasible, not that you give some advice which they cannot practice. You see whatever little possible you have to do it, and if you find that okay, these cannot be managed, then you have to make a provision for referral, the procedures for referral and all those things. I think we will stop the case here, and we will have our 2 more sessions. We will have a break for 15 minutes. We will be meeting here again at 12 o'clock.